has challenge in terms of capacity and also funding. So PSC is supposed to be superintended over by local government.
Are they empowered enough?
But exactly, that is where the challenge is. Now, how do we address that? Is either, that goes through the constitution in terms of saying, look, the issue of primary care should be handled by federal government. But as a way of tackling that major challenge, what we've conceived now at the federal level, which the agency is really driving, is what is known as primary care under one roof. It's called primary health care under one roof. And so far, that has led in the last 2 years, has led to the establishment of 28 primary care development agency at the state level. The idea behind it is that all the primary care centers in the state, all the human resource in those primary care centers, all the capacity building, all the promotion, discipline will now be anchored within the state primary care donor agency, so that there is a proportion of payment between local government and state in terms of contributing to running. And we've seen it work very well in quite a lot of the states. So what it means is that with the PAC under one roof arrangement that we've conceived as an agency, and we are leading in terms of driving, we are tackling that major challenge in terms of the capacity of local government to superintend over primary care centers. Because the reason why people don't patronize primary care center is not because the infrastructure is not there, but because there are ingredients and inputs that determine whether a primary care center is functional or not.
Such as?
Human resource for health. If you go to a primary care center, there is no midwife, or there is no community health officer, or there is no doctor, of course you won't be comfortable to get treated there. If you go to a primary care center, there is no drug, there are no consumables, of course you won't be comfortable. So the primary care under one roof is addressing this. And we're also, within the primary care under one roof arrangement, we've made provision in terms of monitoring the performance of those primary care centers. And in some states already, we've started working on what is known as basket funding arrangements, in which, looking at the fiduciary system, funding will now be domiciled within a basket from government, from partner, and from the states, in such a way that there's transparency and accountability.
We'll go on a short break now, and when we return, we'll look at the implementation of the National Health Insurance Scheme in Nigeria.
The theme of this summit, universal health coverage, the vehicle for sustainable growth and development. We are determined to elevate universal health coverage to a national movement with substantial participation by local and international stakeholders, supported by government and private sector at all levels.
You're welcome back to Dateline Abuja. I'm still here with the Executive Director of the National Primary Healthcare Development Agency, Dr. Ado Mohammed. You're welcome back.
Thank you.
The last thoughts we had was primary healthcare under one roof. Rising from that, I want to know, the National Healthcare Insurance Scheme, what happened about its implementation in Nigeria?
Yes, the National Health Insurance Scheme handles the issue of demand. We handle the issue of supply as an agency, but I will still speak to that. As you are aware, about 3 million Nigerians have been enrolled under the formal sector. Okay. But that is not enough to take us to attain universal health coverage. And as part of the summit we just concluded, it became obvious that the National Health Insurance Scheme is working on the possibility of enrolling 24 million school children under the informal sector arrangement. And in addition, the scheme is also working on ensuring that we scale up on community-based health insurance scheme. Because community-based health insurance scheme. Okay. This is an informal arrangement in which mutuals within every community, they organize themselves into mutual, and then they contribute some stipends monthly so that some minimum healthcare package could be provided for them. Now, this is a strategy that will scale up on universal health coverage, because it will remove financial barrier that has limited people against accessing service.
But isn't the mandate for the National Health Insurance Scheme, isn't it a bit limited in scope? You're just mentioning 24 million school children, 3 million Nigerians enrolled. We have about 160 million Nigerians. Isn't that a bit?
Yes, that's why the new executive secretary is expanding the scope. First, enrolling 24 million pupils, and then also scaling up on community-based health insurance scheme that is presently operational in a number of locations. But scaling up on that so that that will further increase the uptake in terms of universal health coverage.
But at this rate, are you looking to achieving 30%? What's that
30%.
Again? I need to be sure. 30% health insurance coverage by December next year.
We're optimistic. And the reason why we're optimistic is that this movement will kick off on a journey.
Is this about optimism or about what is practically on ground and achievable by efforts ongoing?
It's not as if Nigeria has not been implementing universal health coverage. There are a number of initiatives going on. Because if you look at universal health coverage, there are a number of issues involved. Okay. Physical access. A lot of primary care centers are being built by government, through consultancy projects, by states, by local government, by private sector. Human resource for health. At the federal level, we are supporting states. So far in the last 1 to 2 years, we've infused into the system, recruited and deployed almost 16,000 human resource frontline workers, made up of midwives, community health officers, community health extension workers, and village health workers. And capacity building is ongoing. Commodities are being provided in these facilities, are being supplied. UN Commission on Life-Saving Commodities. 10 essential life-saving commodities are being provided in these facilities. So a number of initiatives are taking place. Now, with the scale up through enrollment of 24 million pupils within the next 1 year, through scale up on community-based health insurance scheme, and then with private sector also coming in, because government alone cannot provide that, So, and with the summit, which was concluded yesterday, the movement has taken shape, and the journey has commenced and is continuing, and we'll get to that destination.
Let's take on this big issue. That is the just concluded 2-day National Health Summit. What is the way forward? What are the challenges we're looking to address? Do you have a declaration? What are the main points of your declaration that Nigerians should be looking forward to for a better coverage in health?
I think one key success of that summit is that all the level tiers of government have agreed that universal health coverage is a game changer, that the way to go is through universal health coverage. And we've received the highest level of political commitment as demonstrated by the statements made by Mr. President to the Vice President. And governors were there, and governors also endorsed what was said, and they've agreed that they are going to collaborate with federal government to ensure that universal health coverage is attained, at least the 30% targets. We've said that by next year, we should be able to achieve that 30% target. Secondly, there are key deliverables and key targets that have been set up that have been agreed upon at that summit. I want to start with geographical access. Okay. Clearly, we agree with all stakeholders that there must be functional primary care center within every 5-kilometer radius of where a Nigerian or any person in Nigeria resides. Functional in terms of availability of human resource for health, in terms of commodities being available in those primary care centers, in terms of quality of care also being provided in those primary care centers. But there are challenges, especially when it comes to human resource for health. And we agree that while in country we can say we have a reasonable number of human resource for health, but if you look at distribution, there is inequity in terms of distribution. And with some location, have enough, others, some are saturated, others don't have any.
Yes.
So we have to look at the issue of redistribution of human resource for health. And then we also have to address the issue of production of the human resource for health, because areas that actually need this human resource for health are not actually producing them. So states and local government, states have been encouraged to start producing human resources for health, to also ensure that primary care centers are being built to address the issue of inequity that has over the years, manifested in terms of geographical access. So that is a concrete, for the supply side, that is an area that we've discussed. Now for the demand side, which has to do with universal, which has to do with community-based health insurance, we've agreed that there's need to scale up to go beyond the formal sector. As I said earlier on, through the formal sector, about 3 million Nigerians under the formal sector have been enrolled to benefit from health insurance.
Okay.
It was agreed that Labour will also contribute, because as it is, it's only federal government that is paying. So Labour will also contribute. That is one. Secondly, that health insurance should also be made mandatory instead of voluntary.
I want you to explain what that mandatory health insurance means. What does that mean to the average Nigerian?
What it means is that everybody has to come on board, because as it is now, it's only the formal sector, and then some voluntary insurance in which you decide if you're not employed by federal government. You can decide to enroll yourself and your family, but that shouldn't be so. It should be mandatory, because people, if you have to attain universal health coverage, there's nowhere in the world where voluntary enrollment has resulted into attaining universal health coverage.
So in other words, you're saying that under this mandatory health insurance, people will be mandated to enroll.
To enroll. But the Act establishing National Health Insurance Scheme has not made provision for that. So the bill is being reviewed now at the National Assembly, and it has passed 3 readings. So that will be incorporated for that to be mandatory enrollment, health insurance.
Who will enforce that?
National Insurance Scheme will enforce that. National Insurance Scheme is a regulatory body.
Yes. Also, part of your declaration was the establishment of an independent health quality commission. What's that about?
Yes, the issue of quality of care is very important, because as it is, even if you've provided health facility, even if the human resource is there, even if you've removed financial barrier, if the quality of care is not there, it's not likely that the customer will be satisfied. It's also not likely that we'll be able to improve health outcomes. What we want ultimately is for health outcomes to be improved. And for that to happen, there must be quality of care. So the standard of practice must be regulated, in which a minimum standard of care must be provided at every level. And for that to happen, there's need to have it.
Now let me ask you a question many Nigerians must want an answer to. 30% target for achieving universal health coverage by December 2015. That is just round the corner next year. Is that achievable really in Nigeria? And what should be looked at now to make that possible?
We believe that the summit that we just concluded has set the pace for that. Post-summit, there are a lot of things that we need to do. First, we have to bring up the roadmap. Secondly, we have to also continue our advocacy. We have to sensitize the public. We have to mobilize the private sector. So all these things are things that we put in place to make sure that we get to that destination. But with the support of journalists like you and then the Nigerians, we are optimistic that Mr. President will deliver on that. We've always delivered in the health sector, and we'll continue to deliver.
Thank you for speaking to us on Dateline Abuja.
Thank you very much.
We went to Gishiri Village, a community in Abuja Municipal Area Council.
This is Gishiri Village within the Abuja Municipal Area Council in the Federal Capital Territory. Basic amenities like water, good roads and health centers are absent here.
We are always climbing to government and give us a medical center here, but no response.
Residents like Christiana Jonah have to make do with the Maitama District Hospital, which is located several kilometers from her community.
No, not only Maitama.
Only Maitama?
Yes.
That's where you'll be taking treatment?
Yes.
Only Maitama.
Maitama, utuse, Guarampa o Asokoro.
However, relief came their way through this community health outreach. This medical service to the community is a joint effort of the Junior Chambers International Nigeria, the Planned Parenthood Federation of Nigeria, and the Institute of Human Virology. The effort is directed at reducing the spread of infectious diseases such as malaria, measles, HIV/AIDS, and yellow fever.
Die from preventable infectious diseases each year, and we are trying to see that the target of Millennium Development Goal number 6 is realized, and that is our motive, and that is what informs what we are doing today.
Throughout this year, we are going to carry a lot of projects out. So after this one, 3 months later, we are still going to come back to Gishiri community to really see the effect of the treatment that we gave them.
This health initiative is just an intervention for a day. Notwithstanding the impact it would have on the people, this community definitely needs a health facility to cater for their health needs.
Thank you for your mails. Keep them coming by sending your comments and views to the address and Twitter handle on your screen. And see you next time.